there is one more eminent faculty, I think, across India, a known face, Dr. Pramila Kalra. She has been there in the endocrinology field. I think most of the SCPs doesn't require the introduction for ma'am, but still it is my duty to introduce ma'am. First of all, ma'am, welcome to the session of ADA 2026. Most of the industry people are talking about it. I think through an expert panel like you, we can able to give this information to all the SCPs. Okay, so that's the reason we have been brought up this ADA 2026 update. And multiple time, if you're able to give this kind of a feedback, I think SCPs will going to get a benefit in their clinical practice. So to introduce Pramila Kalra ma'am, I think she is MD/DM endocrinology, FSC, FAMS, FSCP. Most importantly, 19 plus publication, 32 book chapters, more than national, international in the body. She has been there, president elect in the, if I talk about Indian Thyroid Society, executive editor, thyroid research and practice. A lot of awards ma'am has been achieved. I think if you talk about AV Gandhi Award, AR Sheth Award, multiple best paper rewards has been happened up. And I think most of known about ma'am is heading endocrinology department at Ramaiah Medical College. I think there is no introduction for that particular hospital. I've been also personally met up multiple times ma'am over there. And today ma'am is talking about the most interesting, I think I can expect a lot of questions will going to come up from the SAPs is what's coming is new wave in creating therapy. I think this is the top of the world right now. Most of the SAPs are looking forward in creating therapy. What is coming up? GLP analog was the hot topic. I think, ma'am, towards you, this is a wonderful topic. Even everyone looking forward to hear you, ma'am. I'm just handing over the session to you.
Yeah, thank you. Thanks for the kind introduction. So thanks, Lloyd, for the kind introduction for this talk and for inviting me for this talk. We know that we are all using more and more GLP-1 analogs in our practice, and we know that way back in 2006, when gliptins were first launched in our country, and then we got, that time only we had exenatide, which came in the Indian market, and then we had liraglutide, and then dulaglutide, and now we all know that semaglutide, tirzepatide, all are available in our market. And we know that we need to understand that what's the new thing which is coming up in the incretin therapy. We know that we are now not just talking about GLP, GIP, we are talking about GIP, GLP-1, glucagon triple agonism, that is the retatrutide. And we also know that tirzepatide is already available with the GLP-1 GIP effect. We are also going to talk a little bit about the oral non-peptides, the amylin co-agonists, the pipeline landscape, what is there, what about the cagrilintide, the orforglipron, and the maritide. That's what we are going to discuss. And beyond glycemic control, what are the effects on the arthritis and the body composition? Now, when we are talking about the next wave of incretins, we know that now we are talking more in terms of GIP, GLP-1, and glucagon triple agonism. So if you see the most advanced triple hormone receptor agonist, which is there in the pipeline at the moment, which is the retatrutide, and we know that it works by multiple mechanisms. We know that GLP-1 has an appetite suppression, insulin secretion effect with a gastric emptying reduction so that the patient feels less hungry and they have early satiety. And then we have the GIP receptor effect with the lipid metabolism. It amplifies the insulin regulation and enhanced weight loss happens with that. And then we also have the effect on the glucagon receptor. And the most important take home from this is the phase 2 highlights have shown 22.8% body weight loss and over a period of 48 weeks with the highest dose. And the most important thing, we all know that mast cell is one thing which we always don't know what exactly to offer. We know that now we have data which has come up with the semaglutide of the Essence trial. But we know that with this drug, it was 82.4% relative liver fat reduction, which was seen. And the phase 3 Transcend in type 2 DM is now underway. And we also have the type 2 DM and the obesity trial where they are using it for the dual indication that is also under development. So we know that this triple agonism actually gives the 3 complementary metabolic pathways, and this gives a better glycemic control, a better weight loss, good effect on the mast cells against and protection against weight gain as well. And we know the weight loss happens. Now, when we talk about the GLP-1, the GIP, and the glucagon, we know that the GLP-1 reduces the appetite centrally. It acts at the hypothalamus, and we know that we have a hedonic center, and these drugs have a very good inhibitory effect on that. It stimulates the glucose-dependent insulin secretion. It also slows down the gastric emptying. And we also know that when we are talking about this, we all are aware that reduces the glucagon during the hyperglycemia. So we know that that also is one of the effect which happens. When we talk about the GIP augments the insulin secretion post-meal. It improves the lipid metabolism. It also has an anti-inflammatory effect on the adipose tissue, and it also amplifies the GLP-1 weight loss effect. And on top of that, we know that if the triple effect, which we are talking about, that is the triple is the glucagon effect, which we are also talking about, which there it increases the energy expenditure, that is, it causes thermogenesis. It also promotes hepatic fat oxidation, that is lipolysis. It drives the liver fat clearance. That's what we talked about, the liver fat reduction, the massive benefit, and it raises the resting metabolic rate. So we know that if you talk about triple agonism, the benefit is it is almost approaching the bariatric surgery level. So now we all know that our referrals for bariatric surgeries have come down markedly already. And if we have a drug like this with 22.8% weight loss, we are almost approaching bariatric surgery level. We are giving a superior HbA1c reduction. We are also giving liver a benefit of fat clearance and improving the energy expenditure simultaneously. And we know that none of the available medicines at the moment achieve this three combinations. We know that we have the GLP-1s, which have effect on the GLP. We have an effect on the liver fat reduction. We have the GLP-1 GIP glucagon effect with this medication, which is not available with the any other available drug at the moment. So we know that when we are talking about the other medications which we are already using, that is the tirzepatide, that is the GLP-1 GIP. We know that we have the SURPASS-2, where it showed a HbA1c of 2.46% versus semaglutide 1.86, and the weight loss of 12.4 kg versus 6.2. And we also have the SURMOUNT-1, where it showed a 20.9% body weight reduction at 72 weeks with the highest dose of 15 mg. Also, we know that there was some renal protection signals in SURPASS with a reduction in the urinary albumin-creatinine ratio also. So we know that another indication for which it's coming up is definitely not only diabetes and obesity, but also OSA, which is one of the also major uses of these incretin therapies. Now, if we talk about the peak weight loss or the weight loss which happened in SURMOUNT-1, it was 20.9. The HbA1c reduction was to the tune of 2.46, 18% hospitalization with heart failure reduction. And we also know that in SURPASS-4, that was a CVOT, it showed non-inferiority to insulin. So if you talk about the first phase 3 trial of retatrutide in patients with type 2, that is the Transcend type 2, which was a phase 3, where type 2 diabetes patients who were inadequately controlled by diet or exercise alone with no prior glucose lowering therapy, it was done to see the efficacy and safety of retatrutide as a monotherapy. And they were trying to see the change in the HbA1c at 40 weeks. They were also trying to see the body weight, the fasting glucose reduction, as well as the percentage of patients who achieved the HbA1c target. And they randomized into 4, 9, and 12 milligrams subcute weekly. We know it's a subcute dose. And comparator was a placebo, which was a double-blind study. They did a slow dose escalation to maintain the GI tolerability. This was a randomized double-blind, as we discussed, and it was a multinational 40-week study. So if you see this data, 1.94% reduction of the HbA1c with the 12 milligram dose, 15.3% reduction with the body weight at 40 weeks, and low hypoglycemia risk. Most adverse events were GI, like nausea, vomiting, and diarrhea. And the GI effects primarily happened during the escalation phase and declined. There are no new safety signals beyond GLP-1 class, and discontinuation rates were 8 to 10% at the highest dose. And retatrutide demonstrated definitely a superior glycemic control and definitely a better clinically meaningful weight loss as compared to placebo in type 2. So it's one of the triple agonists which is going to be available for the patients soon. Now, nausea was the most common. We know that we can understand because of the mechanism, the nausea was the commonest, up to 45%. Vomiting and diarrhea were manageable with slow titration. The peak GI effects happened during the dose escalation, which resolved over time. And the profile was consistent with GLP-1 GIP class. So monitoring consideration, if you see, we can administer it at any day of the week. Patient counseling on GI side effects, if it's done before, it definitely improves the adherence, because in our practice also, if you talk to the patient about the side effects, it actually helps the patients better because it improves the adherence, and they tend to tolerate, and they know that this is going to happen, and then they can reduce the discontinuation rates also. Now, coming to the pipeline oral non-peptides and amylin co-agonist, We all know that CagriSema is the one which is being tried now. CagriSema is a GLP-1 semaglutide with the amylin co-agonism. We are also part of the trials of the CagriSema, which are happening at our center as well. So we know that semaglutide, we know there's a GLP-1 receptor agonist. It is a central appetite suppression, but cagrilintide is a long-acting amylin analog which delays the gastric emptying and it enhances the satiety via the area postrema. It suppresses the post-meal glucagon and it has a once weekly subcute dosing. So what was done in the Reimagine 2, they tried to combine the two and they found that there was a 1.9% weight reduction versus 1.76 with sema alone. And when they combined the cagri and the sema, they had a higher weight reduction as compared to semaglutide alone. Low GI tolerability profile, which was as with the other GLP-1. So we know that there are complementary satiety pathways which the CagriSema takes care, GLP-1 receptors centrally and the amylin peripherally. And this delivers a superior HbA1c and weight outcomes versus each of the components individually. Now, CagriSema versus semaglutide versus cagrilintide versus placebo. If you see this, the arm 1 had CagriSema, the arm 2 had semaglutide, and CagriSema dose was 2.4 for both. Semaglutide was 2.4, cagrilintide was 2.4, placebo was weekly subcute, which was a double blind. And they were trying to see the change in the HbA1c from baseline at week 68. And they were also trying to see the superiority of CagriSema versus each monotherapy. And non-inferiority margin was pre-specified. And they were also trying to see the body weight percent change from baseline, fasting glucose reduction, the blood pressure and the lipid profile reductions, and the GI profile tolerability and the safety profile as well. Now we come to another thing, which is the orforglipron, which is an oral non-peptide. And this is one of the game changers because we know there's no injection, no fasting, no cold chain. This is going to give a paradigm shift in the GLP-1 delivery. And if you see the Achieve 3 versus if you see the data of the orforglipron, we know that there was a reduction of 1.56 versus the oral sema, which was 1.47 and 1.9% HbA1c reduction. And we have multiple phase 3 trials which have been completed in the year 2024-2025. Now, the other drug is Maritide, which is by Amgen, and this is GIPR antibody plus GLP-1 peptide conjugate. It blocks the GIP receptor, like tirzepatide activates it, but this blocks. So there is a sustained receptor engagement and it has a once monthly dosing. So that's even better. Phase 2, they have seen up to 20% weight reduction. It has an anti-GIPR mechanism, that is, it blocks the receptor. This may benefit GIP non-responders. So we know that there are few non-responders where this drug can be definitely beneficial. And it is definitely good for maintenance of the weight loss also. If you talk about survodutide, which is by BI, and this is a dual GLP-1 and a glucagon receptor. Now we saw the triple agonism. Now this is a dual where we have the GLP-1 and the glucagon receptor. This is in the phase 2 obesity up to 18.7% body weight reduction. They saw at 46 weeks. And in the MASH trial, they found the liver fat reduction with glucagon component uniquely driving the hepatic fat oxidation. And MASH was the primary indication alongside the obesity. And this could be potentially the first pharmacotherapy which could be approved specifically for only liver steatosis. And this monthly dose of Maritide and liver-specific action, survodutide, could be one of the two unmet gaps which can be addressed by them. That is the less dosing frequent and the liver benefit. Beyond glycemic control, if you see, we know that now there is a paradigm shift with visceral obesity reduction, improved insulin sensitivity, lower inflammation, with a better quality of life. And we know that these incretins affect to every other major organ of the body by reducing the excess or adiposity and metabolic dysfunction. And we know that we are going beyond the dual agonism across glycemia, weight, and organs. More than 25% weight loss may cause reduction in MASLD, OSA, osteoarthritis, heart failure with preserved ejection fraction. Hyperfiltration reduction may happen, renal fat and inflammation, lower cytokine-mediated renal injury, improved insulin sensitivity, lower metabolic stress, better glycemic durability, and reduced adiposity as well with the reduction of the visceral and the pericardial fat, which results in improved cardiac functions. So triple agonism, GLP-1, GIP, and glucagon, this may achieve outcomes in single agents that currently require combinations. So we know that type 2 diabetes control may happen, obesity, MASLD with one single injection or single pill with a CV protection. So if you talk about OA reduction, we know that osteoarthritis therapy, if you see the step 9 with the GLP-1, it found that semaglutide definitely demonstrated a better reduction of the osteoarthritis pain and the function. And we know that joint reduction, the loading comes down with the weight loss. There is an anti-inflammatory action. We also know that we have multiple other studies, like with retatrutide, we have the Triumph 4, where they found that even more weight loss may improve the pain scores even more. So integrating this obesity treatment into the routine OA management could be reducing the disease burden. We recently had a good number of patients who were referred from orthopedician for osteoarthritis and obesity, and we started the GLP-1 analogs. And after their weight loss, actually, many of them were planned for joint replacement, but their pain came down so much that they refused to go for joint replacement. So the orthopedician was definitely not very happy with us. So if you see non-arthritic anterior ischemic optic neuropathy, we know that there is some concern with the semaglutide and with the other GLP-1s. We know that there was with the other drugs, if you see with dulaglutide, sitagliptin, and glipizide, they did not find any major increase. Incidence is very, very low. We do not, they're not recommending any blanket discontinuation, but we have to have an ophthalmic evaluation before we start, at least see the cup disc ratio and get a retinopathy evaluation also, because if it is severe diabetic retinopathy, that again becomes a relative contraindication. But CDR ratio, cup disc ratio is one of the good parameters to see, but still we cannot absolutely rule it out. And we have to tell the patient there's a very rare risk, which we have to always keep in mind. And we know that patients' weight loss happens, but at the expense of some amount of lean mass loss also. So we know that there is some amount of lean mass. There is also loss of muscle mass. But we also know that muscle loss lowers the resting energy expenditure. There is functional decline which might happen. And after treatment discontinuation, they may have more of fat mass which goes up. How to prevent this? A good protein intake recommendation is more like 1.5 grams per kg, but most of our patients not even cross 1 gram. But at least we should try to achieve that 1 gram. Resistance training is the most important thing. A simple TheraBand exercises, resistance band exercises can be taught to the patients when we are treating starting GLP-1 analogs for them. We can teach them in the OPD itself so that they can do it, which can prevent the muscle loss. We also know that there are some anti-activin type 2 receptors which have been used to cause weight reduction up to 20.2%. We also know that there are some other combinations which have been used which help more fat loss and lesser of lean mass loss. Dietary protein recommendations, I already told you, 1.6 grams per kg per day, but 25 to 30% of the calorie intake should be from protein. We should see that they take high quality protein, but in our country, we need to see that at least they can take egg white and those things. Otherwise, they can take pulses and sprouts and dairy products to some extent. Adequate fiber intake is more important, and fluid intake is also very important, because many of these patients tend not to drink enough water and they get dehydrated and they land up with constipation as well. Resistance training is very important. We need to educate the patient about resistance training, aerobic exercises, progressive overload principle, not a sudden overload. And we know that exercise training also improves insulin sensitivity and energy expenditure. So if you see the S-Lite trial, it demonstrated that the combination of semaglutide with dietary protein guidance actually produced the best preservation of the lean mass and skeletal mass along with the exercise. So we know that only pharmacotherapy is not enough. We need to counsel about protein intake and good amount of exercise as well. Now, if we come to the practical framework, when we are talking about a patient who's on GLP-1 for their nutrition, it has to be a structured meal timing, avoid the prolonged fasting. Small frequent meals are important, which help to manage the GI symptoms. They should pause the late night eating, time restricted feedings, definitely, because it supports the circadian rhythm, reduces the postprandial GI burden. As I told, protein intake, at least we should target 1 gram, if not more than that, but 1.2 to 1.5 gram is what we are trying to target. Physical activity, more than 150 minutes per week of aerobic exercises is very important. A good amount of sleep is very, very important, which we say pillow time, at least 7 hours is important, because sleep deprivation definitely leads to more insulin resistance, weight gain, and GLP-1 receptors signaling is also impaired, and the weight loss benefit does not happen. So what we know is tirzepatide already is there, GLP-1 and GIP, which is approved for type 2 diabetes and obesity, OSA. This is one of the efficacy benchmarks. Oral semaglutide already there, but orforglipron is there to surpass it because it's an oral drug. We know the SELECT trial has shown that the GLP-1s are good for the heart, even in non-diabetic obese patients. Flo definitely told that GLP-1 oral semaglutide is good for the kidney protection. What's coming up is retatrutide, that is a triple agonist. Phase 3 surgeries are maybe out of after the phase 3 trials, the bariatric surgeries may go off. We don't know because the amount of the weight loss is almost equal to the bariatric surgery. Cagrilsema, the GLP-1 plus amylin, definitely a superior weight loss with a complementary satiety pathway. Maritide, once monthly dosing with the anti-GIPR mechanism, convenience dosing for the patient because they just have to take once a month. Survodutide with a dual GLP-1 and glucagon, definitely for MASH. Beyond glycemic control, we are talking about MACE reduction. We have the data from the SELECT trial. We have data in heart failure with preserved ejection fraction also from the STEP heart failure with preserved ejection fraction. Sleep apnea, also 55% remission was seen with tirzepatide in the SURMOUNT OSA trial. Liver, we saw 59% MASH reduction, and we also know with retatrutide, we saw 82% liver fat reduction with the triple agonist. Osteoarthritis, another added benefit because we know that overweight and obesity leads to more of joint issues. So osteoarthritis is another added benefit which we get when we use these drugs for our patients. Thank you. With this, I end and we can take the questions if there are any.
Thank you so much, ma'am, for the wonderful session. I think probably around 40 minutes we have been spoken about it, about the incretin therapy. It's a very long and lengthy topic, ma'am, but you have been covered between this 35 minutes. There are a lot of questions has been there, ma'am, but I had just shortlisted three, which I can have a word with you, ma'am. The first, I think it is more prominent because one GP, Dr. Yogesh Patil, was been there. He's speaking right now. Probably he's been seeing most of diabetes patients. His question towards you, ma'am, is that multiple incretin, including tirzepatide, like what you have been mentioned, ma'am. So I think it is quite been exciting news and overwhelming. But for a GP, wants a simple rule of thumb, which patient should I escalate to a specialist? I think he is rightly asking that particular question, ma'am.
Yeah. So very important pertinent practice question. So if you have a patient who has come to you with overweight, with at least one weight related comorbidity, and overweight for the GLP-1 clearance is 27 kg per meter square. We don't have we have the BMI cutoff of 27. So 27 obesity is like BMI more than 27 with one weight related comorbidity. Then you can use a GLP-1. Even if they don't have diabetes, they have any other weight related comorbidity. BMI more than 30 kg per meter square, you can use it even without even a single weight related comorbidity. So above 27 with one weight related comorbidity, we have the approval for GLP-1. Above 30, we have approval even without a single weight related comorbidity. But GLP-1 analogs are also approved as a drug for obesity. And they are also approved as a drug for diabetes. So you can use a GLP-1 analog in a patient with diabetes, irrespective of the BMI. At any BMI, that's your decision. But normally, we don't use it in lean diabetes. We use it mostly in overweight and obese diabetes. And for our country, the overweight cutoff for BMI is above 23. For obesity, the cutoff for our country is above 25. So if you have a patient with diabetes who is having any BMI, if it is type 2, you can use it. It's irrespective of the BMI actually. So, but we mostly prefer it in overweight and obese diabetes patients.
Thank you so much, ma'am. I think that's more than sufficient for that particular doctor to look after that particular therapy, how we're going to use it. Now, coming to Dr. Ashia Sheikh, she is an MD physician from Latur. She is talking about, ma'am, the weight loss numbers has been quite encouraging by using SEMA. I think she started using Ozempic, ma'am. But what happens if the patient stops? Do we create any dependency on that particular molecule? Are we creating? How to take that conversation with a patient? That's what the question. Practical, I think, practical question.
Yeah. Yes. So it's very important. So when a patient walks to the clinic, suppose you are using it for diabetes, then there is no problem. You can say that as you are taking other medications for diabetes, you have to take this, and we will continue on a maintenance dose once the glucose control and other things are in range. But when you're talking to a patient with obesity who does not have diabetes, like I told you, 27 and above BMI with one weight-related comorbidity, or above 30 with no weight-related comorbidity, and I'm starting for that. And the next question patient asks, how long? Actually, the answer is that the patient has to continue on the maintenance dose, because if they stop it totally, they'll regain the weight over a period of time. Well, after 1 year, they may regain about 70% of the weight, and that's what the studies have shown. But how we convince a patient is, if your patient is having diabetes, we say that as you are taking other medications for diabetes, you please take this, because this is going to be one of the good anti-diabetic drug, which is going to give you renal and heart protection as well, with a weight loss benefit. But if I and a glycemic control benefit for sure. But if I'm using it for obesity, what I tell my patients, you take it for a year, let's see how you do, and then we'll decide about your maintenance dose. Like outrightly, if we say that if you have to continue, we know that they have to continue on a maintenance, because if they stop, they'll regain the weight. But outrightly telling something that this has to be continued on a maintenance, there may be less takers for it. So we do the good work for the patient, let the patient lose some weight. Once they lose weight, actually in 6 months to 1 year, they feel good, and they most of the time decide to continue on a maintenance. So this is how it works. Once the patient sees the good effect, they themselves take a call to continue. So we can do it in a great way rather than just telling them that you have to take it always.
Thank you so much, ma'am, for the wonderful insights to that particular doctor. I think there are 3 to 4 doctors are asking the same question. So I thought about to choose that particular question, ma'am. I think you also know about this Ozempic and that eye relation. Any comment from your side? Because
Yes.
they are into
So,
a
so
dilemma, ma'am. Yeah.
yes.
Yeah, please.
So if your patient is a diabetic patient, always get a retinopathy check. If it's a severe proliferative diabetic retinopathy, better not to start. But there is another which we discussed about the neon, which we discussed, and I showed the slide as well. So what happens that the data is there, but these are all observational big studies where they have taken from the data set and seen that these patients got the eye problem. Now, we cannot predict if your patient will get it or not. So, if you have a patient with obesity who has normally nothing, get an eye evaluation done before starting it. Get a cup disc ratio. So, if the cup disc ratio is less than 0.3, now this is also very arbitrary, it's not a foolproof thing. But if it's less than 0.3, if it's a crowded disc, their risk of getting this complication of neon is a bit high. If it's 3.3 or more, the risk of getting this complication is less, but it's not zero. So you have to counsel that this is a very, very rare side effect. We cannot predict which patient will get it. We can do an ophthalmic evaluation, we can do a OCT, we can do a cup disc ratio, we can predict your risk, but we cannot predict 100% risk. So if the CDR is less than 0.3, we sometimes don't start. But if it is more than 0.3 or zero point 0.3, then you cannot predict that whether this patient will get it. They might still get it. Even we have no 100% foolproof manner to predict, but this is good to tell to the patient so that they are aware, but not in a way that they don't take the drug. So we tell them that it's mostly observational. We don't have 100% evidence. We really don't know whether it causes or not. There may be, in a general population also, the same incidence may be there, even if they're not taking GLP-1 analog. So we get an ophthalmic evaluation, we get a periodic evaluation. If you have any visual symptoms, report to us immediately.
A wonderful answer, ma'am. I think with a safety and even taking precaution, I think that question has been get clarified. One doctor has been forcing me to ask this question, ma'am. This is in front of me. He's talking about more of tirzepatide and semaglutide. Okay, so semaglutide is more cheaper than tirzepatide. So he wants your opinion, and he's from Bangalore only, ma'am.
Yeah, so if you have tirzepatide and semaglutide, now we know that tirzepatide is costlier. So it depends on the patient. So offer it to the patient, whatever you think the patient is the right candidate. So we have data with cardiovascular benefit for semaglutide. Now we have some data with tirzepatide as well. But maybe semaglutide scores 10% higher in the cardiovascular benefit data. Maybe tirzepatide scores 10% higher in the weight loss benefit. So if your primary target is weight loss, you may err towards tirzepatide. If your primary target is more of cardiovascular safety, diabetes, then you may err towards semaglutide. But these are very arbitrary things. Again, it is just arbitrary, I think, because we have some data coming up now with tirzepatide also with better cardiovascular outcomes. So the cost is a deterrent because we know that generics are available. So generics, if the patient wants to take generic, we don't have a tirzepatide generic. We have to offer semaglutide, and we have the drug controller of India who has approved these generics. So we are safe to use it because the drug controller has approved. So we can use them. And in case the patient wants to take tirzepatide, we can offer it. Definitely, there's no problem. The cost, if the patient is not having a constraint, we can still offer that, and that's a good drug. That's a fantastic medication. No controversy on that. But if the patient wants lesser cost, cheaper drug, generics are available. We use it. We are using it in our practice. The generics which have been approved by drug controller, we are definitely using it.
Thank you so much, ma'am.